Welcome back, everyone, for block 2 of our Fundamentals of Addictions course. Just a reminder that you can enter questions at any point into the chat, and they'll all be brought forward for the question and answer session at 2:30, which will involve all of the speakers from block 1 and block 2. Our next session is on alcohol use disorder with my co-chair of today's course, Dr. Melanie Willows, who is an assistant professor at the University of Ottawa in the Department of Family Medicine with a cross appointment to the Department of Psychiatry. She's an active teacher at the University of Ottawa, providing both didactic lectures to medical students and regular clinical supervision to medical students, psychiatry residents, and family medicine residents. She is the first program director for the newly created Enhanced Skills Addiction Medicine Fellowship Training Program in the Department of Family Medicine at U of O, and she provides clinical and academic leadership in addictions and co-occurring disorders within her department, her hospital, and her community. She's been working at the Royal Ottawa Mental Health Centre since 2001 and is the clinical director of its substance use and concurrent disorders program. She's a clinical investigator with the Institute of Mental Health Research with the University of Ottawa, and she is past president of the Canadian Society of Addiction Medicine. My memory is a little faulty, but I think she may have been our first female president of the organization. And yes, my memory is served. So that's good. So with no further ado, Dr. Willows will walk us through the exciting world of addiction use disorder.
Thank you, Ron. Welcome back, everybody. Oh, I'm already having technical difficulties. Oh, there we go. Sorry, I just want to speak to disclosures. So I do not have any conflicts of interest to declare or relationships with the pharmaceutical industry. These slides are based on previous CSAM fundamental lectures, and I specifically want to thank Dr. Sharon Vipler, who presented last year, and many of these slides have been adapted from her presentation. I'll also be speaking about off-label use of gabapentin and topiramate. And as far as my clinical work that I do, over the last 5 years, I've provided a lot of treatment to individuals with alcohol use disorder through our rapid access addiction medicine service that specifically targets individuals who've been in the emergency room or admitted to hospital, and they're directed to this clinic so that they can receive immediate care. Within the hospital that I work in and the program that I lead, we also have a medical withdrawal management unit where, again, we treat a large number of individuals with alcohol use disorder and complicated withdrawal. So today, what we're going to talk about, we'll talk a little bit about screening tools, and some of this will be a bit of a review from earlier today from Dr. Martel's talk. We'll also talk about the diagnostic criteria for an alcohol use disorder, talk about tools to recognize alcohol withdrawal and what those risks may be, and how to manage alcohol withdrawal. We'll also talk a little bit about anti-craving medications in the treatment of alcohol use disorder. So further to some of the data and information that Dr. Fraser earlier shared with us, we know that alcohol causes a great deal of morbidity. Every day, there's 10 Canadians that die in hospital from the harm caused by substance use, and 75% of these individuals, the deaths are due to alcohol. To put it in another context, when we look at hospitalizations for alcohol, there's actually more hospitalizations for alcohol than there are for heart attacks. And if we look at the amount of money spent related to the harms of alcohol, and this would be in many different domains, and we look at other substances, we can see how much more money is spent on alcohol compared to any other substance. And the only other substance that comes even close to alcohol is tobacco, and the next one is cannabis. And interestingly, those are 3 substances that are now legalized. Earlier this morning, Dr. Fraser talked about risk factors such as, do people have access to the substance? Do they use the substance? And if we look at alcohol, you'll see the large percentage of Canadians that use alcohol. It approaches 80% for most groups. You'll see that for the most part, except for the older cohort, that men and women are close to equal in whether they use alcohol or not. You'll see that the largest group is in that 25 to 34 age range, followed by the 18 to 24 age range. And also further to Dr. Fraser's comments around, trying to delay substance use to as late as possible, you'll see that about 50% of that underage group has consumed alcohol in the past year. What has the pandemic done to alcohol use? I don't think any of us would be surprised to know that many people have increased their use of alcohol since the COVID pandemic. And the individuals that are most at risk are those who have a current substance use disorder, a lifetime substance use disorder, or those who have current or lifetime mental health issues. And we earlier spoke about that interaction between and that increased risk of individuals developing a substance use disorder if they have pre-existing mental health conditions. There's been several guidelines and quality standards developed here in Canada, and some of the things that I'll be talking about today have come from some of these guidelines. One of them has been put forward by the BCCSU, Provincial Guidelines for the Clinical Management of High-Risk Drinking and Alcohol Use Disorder. In Ontario, we've developed quality standards of what the expectation of how this health condition of alcohol use and alcohol use disorder should be treated, and what families and individuals should expect to receive as care. These are probably stretch goals, and that certainly not all of these things happen right now at what we strive for. And then there's also been specific Canadian guidelines put forward to address alcohol use in older adults. So Dr. Mertel spoke about screening and screening for substance use. And I think, before we get into some of the specifics, I think some of those basic strategies of being approachable, of making sure that you do not use any stigmatizing word in your language, using those motivational approaches, all of those are going to be so important as you go through, taking history and caring for those who may use alcohol or may have an alcohol use disorder. So first of all, we would start by asking someone whether they consume alcohol. If the answer is no, we might provide a little bit of education around low risk drinking. If the answer is yes, then we may move to that single alcohol screening question. So how many times in the past year have you had 5 or more drinks a day for men, or 4 or more drinks a day for women? And if the individual answers that they've had any heavy drinking days, then you would go on to ask further questions. So asking them how many days a week they drink, how many drinks in a typical day, and further assessing whether this person might have an alcohol use disorder or not. So let's just use an example. So this isn't an uncommon occurrence where this young man, Ryan, he presents after he's been to the emergency room. He follows up with you 2 weeks later after experiencing an ankle sprain. And that ankle is healing well. The history is that he stumbled on a sidewalk after dinner out with friends one night. And so you decide that you're going to screen him and ask him about alcohol. And you ask him how many times in the past year has he had 5 or more drinks. And he answers maybe once or twice. And when you ask him further questions about how often he drinks and how much he drinks, he tells you that he has 1 to 2 drinks about 3 to 4 nights a week. But on weekends, he routinely drinks 4 drinks, usually in a social setting. So as you ask Ryan further questions, keeping in mind the DSM-5, and Dr. Martel earlier had given us some ideas on how you can ask these questions in a more welcoming way, as opposed to just as a checklist. But as you ask him these questions, it turns out that no, he doesn't have cravings for alcohol. It isn't taking up a lot of time in his life. This is the first time he's ever had an injury when he's had a few drinks of alcohol. And he can go long periods of time and not drink alcohol or even think about alcohol. And so when you go through those criteria, you see that he actually doesn't meet any of the criteria and does not have an alcohol use disorder. However, he is engaging in alcohol use that is slightly above the low risk drinking guidelines. And so what you would look at is conducting a brief intervention, and Dr. Martel had referred to, the frames, giving people feedback, responsibility, advising them, giving them options, taking an empathetic approach, and self-efficacy. So in order to give someone feedback, it's important to know and understand what the low risk drinking guidelines are. It's also, as you're taking history around alcohol, it's important to know what a standard drink is. And you'll see a picture here with different types of alcohol, beer, cider, wine, distilled alcohol or hard liquor. And you'll see that different quantities of that alcohol equals a standard drink. And so in order to give feedback to individuals, you need to understand what a standard drink is, and you need to ask very specific questions to your patient so that you understand exactly how much they're drinking. So if I'm asking someone how many beers they're drinking, I'll ask them what size those beers are, maybe what strength of alcohol they are. If I'm asking them, if they mention that they drink wine, I'll ask them how big the bottle is that they purchase, how many of those bottles they go through, so that I make sure that we're all speaking the same language and that I'm not underestimating or overestimating how much they're drinking. If we look at the low risk drinking guidelines, which give us a framework to provide people with feedback around their drinking, even if they do not have an alcohol use disorder, but more around this idea of prevention and reducing risk. So you'll see that the guidelines, which suggest that for women that they have no more than 10 drinks a week and no more than 2 drinks on a particular day, and that for men they drink no more than 15 drinks per week with no more than 3 drinks a day on any given day. And that ideally they plan to have at least 1 day a week where they do not drink alcohol so that they do not develop a habit. Also, you'll see in the low risk drinking guidelines the recommendation of not consuming alcohol while pregnant. There's also certain scenarios where the recommendation would be for alcohol to be 0, and that would be in situations where you might be operating machinery, where you might have specific physical health or mental health problems that alcohol may make worse. And you'll see a list of other particular areas where 0 is recommended. It's also recommended for young people, wherever possible, to delay the onset of their drinking. And you'll see on the far side of your screen that there are different low-risk drinking guidelines for older adults, and that as individuals become older, their body often does not process alcohol as well, and there can be increased harms. So you'll see that the numbers for women, they recommend no more than 1 drink on any one occasion. For men, no more than 1 or 2. and for women, no more than 5 drinks per week, and for men, no more than 7 drinks per week. And again, that idea of having at least one day where you're not drinking alcohol so that you do not develop a habit where this is something that you do every day. The important thing to note is low risk guidelines mean just that, low risk. Doesn't mean no risk. And obviously, to have no risk would have to be to not consume alcohol at all. As far as brief interventions in primary care, this has been studied specific to alcohol. And there's a review of 34 randomized controlled trials. And what they found in primary care specifically is that with brief intervention, that there was lower alcohol consumption compared to the control after 1 year follow-up or longer. And that these sessions didn't have to be long. And I think sometimes that's where people decide not to have these interventions because they think of them as being something that they don't have time for, that this is going to take 30 minutes. This can take as short a period of time as 5 minutes. So if we move on to another case, this patient is Ricky, and Ricky has been seeing you for a while, and you've noticed his blood pressure has started to creep up, despite the fact that you have him on several different blood pressure medications, and you've really optimized his treatment. And so you're aware that when people drink alcohol, sometimes it can cause blood pressure issues. So you ask him about his alcohol use. And you present it in a way that he feels comfortable sharing with you what's been going on with his drinking. So he shares that he's been drinking 12 beers per night. And until a few years ago, he was drinking about 6 to 8 beers per night, but slowly noticed that he just wasn't getting the same buzz unless he drank more. So it's been gradually increasing. And that by dinner, most days, he feels a bit sweaty and shaky. He usually starts drinking around that time. Notices after he's had 1 to 2 drinks that his mood starts to improve. And that although he doesn't start drinking at lunchtime, he notices by about noon and into the afternoon, he's really having cravings to start drinking. He shared with you that he's been showing up late for work recently, and this has happened repeatedly. And last week, his boss told him that he needs to take some time off to sort himself out. So with Ricky, again, you ask him different questions about his alcohol use, and as you talk to him, he does tell you that he's been using more than what he's intended. He has those cravings. He's already shared with you about how he's having trouble at work, and in fact, he's been asked to take some time off. He's again, having problems. His blood pressure has continued to be elevated, and that's likely related to the alcohol. He's developed tolerance. He needs more alcohol to get the same effect. And he's starting to notice withdrawal symptoms and really needs to have that alcohol to take those withdrawal symptoms away. And so in Ricky's particular case, he actually has more than 6 of the criteria for an alcohol use disorder. And so you diagnose him with an alcohol use disorder severe. Now, if we look through the screening pathway in someone who has been diagnosed with an alcohol use disorder, we want to look at several different factors. So first of all, we want to look at withdrawal management. And that's assuming that Ricky actually wants to make a change to his alcohol use. And I think if we go back to our principles of motivational interviewing, just because Ricky has high blood pressure, and just because his boss has told him to take some time off, and just because maybe we think that Ricky should do something about his alcohol problem, doesn't necessarily mean that Ricky is ready and willing to do something about his alcohol use. So part of this assessment, before even going into some of these different treatments, is actually assessing his readiness to change. And some of that will, again, those open-ended questions to let him talk about what his concerns are, what's important to him, if he was to want to change, what some of those motivators might be, and getting a better understanding of where he's at and what he might be willing to do. So assuming that Ricky is interested in getting some help around his alcohol use, one of the things you're going to want to look at is what is his risk of having significant withdrawal? And if he wants to stop drinking, how would we manage that withdrawal, or what would be the safest way? Again, if he's interested in some treatment for his alcohol use, we might also want to talk to him about pharmacotherapy and some of the relapse prevention meds. And then we also want to look at what other types of treatments and supports could we connect him with. And again, we're going to want to ask questions about, has Ricky had treatment in the past? If he has, what has been helpful? What is he willing to do? What is he not willing to do? What types of things would he be interested in? Whether that's, group things, individual things, treatment programs where he might have to actually leave his home. And so just exploring what he would be willing to do. Again, we might decide, we might say, well, the right match to his severity would be a certain treatment pathway, but that may or may not be what Ricky's ready and willing to do. So if we talk about withdrawal management, so with alcohol use, there's neurobiology that explains why we see some of the symptoms that we see. And so normally in our system, we have GABA and glutamate receptors that are generally, when we're not using alcohol, in homeostasis. When someone becomes intoxicated or drinks alcohol, we have an imbalance where we have potentiation of the GABA and some inhibition of glutamate. And what that results in is that feeling of being relaxed, maybe some reduced inhibitions, maybe impaired balance, maybe, on some, depending on how much you drink, a decreased level of consciousness. As someone continues to drink over and over again and develops dependence, or that physical dependence, and usually that takes, daily drinking, reasonably large amounts of alcohol on a daily basis, the body creates a new equilibrium where the GABA receptors have been downregulated and the glutamate receptors have been upregulated. And so now we have a balance where that person may not seem as intoxicated as someone else who has that same number of drinks because of that tolerance and that change in these receptors. Then if all of a sudden that individual decides, or for some reason, alcohol is taken away and they don't have access to alcohol, what we see is this imbalance where we all of a sudden see that that prevalence of that upregulation of those glutamate receptors, and we see this hyper excitable state of the central nervous system. And what that's going to look like is shakes, seizures, and changes in heart rate and blood pressure and sweating, and all those symptoms that we see as part of alcohol withdrawal. So in individuals that are long-term heavy alcohol use, we're talking about daily use with large amounts of alcohol, about 50% of those individuals will experience withdrawal symptoms when they stop alcohol use. That can also happen even if an individual greatly reduces the amount they drink. They may not stop completely, but if somebody was drinking, say, 40 ounces of alcohol and then one day drank 13 ounces of alcohol, you likely would see significant amounts of withdrawal. For most people, the symptoms will be mild to moderate. And typically what happens is you'll see these symptoms develop anywhere from about 6 to 24 hours after the last drink that the individual has had. The peak, or where you see the most severe symptoms, is usually around the 24 to 48 hour mark. And generally the symptoms should resolve within about 5 to 7 days. And this is important to remember because when we're treating alcohol withdrawal, we need to know that we actually only need to treat it for that 5 to 7 days, not a much longer period of time. At its worst or at its most severe, we can see seizures, delirium tremens, and even mortality. And so often when we talk about alcohol, we talk about it as being the one substance where withdrawal can be life-threatening. So about 10% of individuals will develop seizures, and they look just like epileptic seizures. They're generalized tonic-clonic seizures. And typically those will occur anywhere from 6 to 48 hours after the last drink. Delirium tremens, this occurs in about 3 to 5% of individuals. This usually begins about 48 to 96 hours after the last drink. And in this individual, you'll see severe confusion, disorientation, hallucination, and very severe autonomic hyperactivity. So tachycardia, hypertension, hyperthermia, agitation, and sweating. And this is treated in an acute care hospital, often in ICU. And then, as mentioned, individuals can experience mortality from alcohol withdrawal, and it's considered to be 1 to 4%. One of the ways, so when we look at an individual who is drinking large amounts of alcohol, and this individual actually wants to stop drinking alcohol, the first question or first thing comes to mind to me is, okay, they're ready to stop, but is it safe to stop? And if it's safe to stop, and when we're looking at whether it's safe to stop, in what way is it safe to stop? Is it safe to stop without medication? Does it require medication? And what kind of setting should this person be in if they're going to stop drinking? And this study looked at a tool called the pause to predict who do we need to be worried about. Now, keeping in mind, this did look at studies of inpatient patients who were hospitalized in acute care facilities. And from this study, the likelihood ratio, there was a likelihood ratio of 174 when patients had 4 or more of the individual findings on pause, and I'll show you the tool in a minute. And if they had 3 or fewer, their likelihood was 0.07. So I'll show you the prediction of alcohol withdrawal severity scale. So there's several different parts to it. The first part asks, have you consumed any amount of alcohol within the last 30 days? Or did the patient have a positive blood alcohol on admission? So if the answer is yes, you proceed. If the answer is no, then you don't proceed. So it's basically a screening question for hospitalized patients. Part B goes through different questions that are identified as potential risk factors for developing severe alcohol withdrawal. So have you been recently intoxicated or drunk within the last 30 days? Have you undergone alcohol use disorder rehabilitation treatment or treatment for alcoholism? Have you experienced any previous episodes of alcohol withdrawal regardless of severity? Have you ever experienced blackouts? Have you ever experienced alcohol withdrawal seizures? Have you ever experienced delirium tremens or DTs? Have you combined alcohol with other downers like benzodiazepines or barbiturates during the last 90 days? And have you ever combined alcohol with any other substances of abuse during the last 90 days? So many of these questions, we know that individuals who've had seizures before will be at high risk of having seizures again. Individuals who have had delirium tremens before are at high risk of developing delirium tremens again. Individuals who are using alcohol and benzodiazepines, there is much higher risk, and it's much more challenging to manage their withdrawal. So again, if the answer is yes to any of these, the individual would get 1 point per question. And then the last section is based on clinical evidence. So it asks, was the person's blood alcohol level on presentation greater than 200? And the last question, is there evidence of increased autonomic activity? So seeing that increased heart rate, that tremor, sweating, agitation, nausea. So although this pause scale has been used to predict withdrawal in inpatients, it has in some cases been adapted to look at what are those risks for outpatient treatment of alcohol use disorder, and looking at those scores to determine what pathway and in what way are you going to treat that individual. And so you'll see with the pause less than 4, that would be identified as somebody who's low risk for severe alcohol withdrawal syndrome, and that person might be suitable for a trial of outpatient treatment if there's no contraindication. If the person has a pause that's greater than or equal to 4, then they may be high risk for severe alcohol withdrawal syndrome. And this might be an individual that you would want to refer for inpatient treatment in a detox facility or hospital. Although it's not on the tool, clearly you're going to want to ask questions. Without using a tool, the kinds of questions I typically ask people are, first of all, figuring out how many drinks of alcohol they're drinking per day. And again, making sure I'm using those standardized drinks to determine what that number is. And depending on what sources you read, generally, if you're over eight standard drinks a day, increases the chances that you're going to experience withdrawal symptoms. I also often ask people what time of day they start drinking. So if someone does not start drinking till 5 o'clock at night, I'm not as concerned as someone who says they have to drink first thing in the morning, or someone who says they even have to drink through the night. If they wake up in the night, they have to have alcohol. Again, those questions around have they had seizures before, have they had delirium tremens before, are other things that I'm going to want to ask. The other things that we're trying to, so as mentioned, I work in a RAM clinic, so it's an outpatient clinic where we can actually offer intensive withdrawal management for individuals who would actually come to the clinic every day. And then we also have medical beds that are monitored 24 hours a day by nurses and physicians. And then we also have in the community a withdrawal management setting where it is not staffed by doctors and nurses, but you can send a prescription for medication and the person will be somewhat monitored and sent to the emergency room if things become out of control. So we could have a whole talk on withdrawal management. So I focus mainly on outpatient withdrawal management. But if you were to look at inpatient management, most acute care hospitals will have CWA protocols using the CWA tool to score the person's actual withdrawal symptoms. And most hospitals will have a protocol as to how many milligrams of diazepam or lorazepam you might give that individual to treat that withdrawal. So as far as for outpatient management, again, depending on your setting, if you're on your own or you're a family doctor in your office, you're going to probably want to focus on those that are the lowest risk. And those that are at low risk, usually you can use gabapentin off-label. Usually it's prescribed 300 milligrams 3 times a day, and they can add another 300 milligrams PRN 3 times a day up to a dose of about 1,800 milligrams. Sometimes you can even go a little bit higher. Usually we give thiamine to everyone, whether they're low risk or high risk. It's very cheap. It doesn't have side effects. And you'll see different dosages recommended. This particular reference is 100 milligrams 3 times a day. I've seen references that say 300 milligrams once a day, 100 milligrams once a day. I've seen them listed as anywhere from 3 days to 5 days to 7 days to longer. So the bottom line is just make sure you give thiamine, and that's to help reduce the risk of Wernicke's encephalopathy. If you're going to attempt an outpatient detox, you're going to want to make sure that the person has a safe place to live. And if you're going to use benzodiazepines, ideally you can see that person on a regular basis and have daily dispense, whether that's daily dispense at a pharmacy or a family member controlling that medication. And for inpatient management, generally we do use benzodiazepines because these are generally individuals that have much more severe withdrawal. So again, as mentioned, we could have a whole session, but as far as outpatient management, often for those low risk cases, we would use gabapentin, and then if you're able to monitor individuals more closely, you might use diazepam or lorazepam, often in a fixed dose because the person can't do their own withdrawal scale. I think I've already gone over most of this. Just one important point. If you're prescribing benzodiazepines, they only need to be prescribed for about 5 to 7 days maximum. The biggest mistake I see is where individuals are given a 30-day prescription for benzodiazepines for alcohol withdrawal. And usually what happens is they just keep taking them and keep drinking, and then they end up having a more complicated presentation to try to withdraw in the future. So I've only got a little bit less than 10 minutes left. So just going to briefly talk about some relapse prevention pharmacotherapies. Tabitha is a 54-year-old woman. She comes to your office. She's very frustrated. She's just been released from hospital. She's had many admissions to hospital. She continues to drink. She's very frustrated. She's gone to AA and some other self-help groups, and she's asking, is there anything else that can help me? I think there's a lot of other psychosocial interventions that could help her. And I know that Dr. Fraser spoke about some of these different psychosocial interventions. I'm just going to focus on some of the medication interventions. So first line treatment, naltrexone and acamprosate. Second line, off-label, gabapentin and topiramate, and with caution, disulfiram. And I'll go quickly through this, but I just want to point out that our numbers needed to treat are for naltrexone, it's about 12. And although that may seem high, it's actually much lower than if we look at some of our hypertension medications or some of our cholesterol medications that are just routine that we prescribe all of the time. So for naltrexone, and often this is the first line treatment that we will try with some, unless there's contraindications. So if the person is on an opioid antagonist, so if they're on methadone or buprenorphine, we can't use this medication. If the person has really severe hepatic dysfunction, cirrhosis, we probably aren't going to use this medication. Generally, the target dose is about 50 milligrams once daily. It's important to know this medication is quite expensive. It's somewhere between $200 to $300 a month. So depending on where you are, there might be provincial coverage for it, or there may not be, but it's important to know whether the person can afford it. Generally, people receive less pleasure derived from drinking when they're taking naltrexone. I would say that I kind of see three groups of patients. I see some groups of patients where they feel like it immediately takes away all their cravings and they can't believe it and they don't know why somebody didn't tell them to take it 5 or 10 years ago. Other people where they see a reduction, and some people where they see no effect. You don't really know until you try it on that person. Most common side effects: headache, dizziness, and nausea. Most times it goes away. Sometimes it's intolerable and people can't continue the medication. Acamprosate is another approved anti-craving medication. Generally, it's recommended this medication is started 3 or 4 days after a person has stopped drinking. The major side effect is diarrhea. You can see 17%. Most people tolerate it well, but some people have to discontinue it because of that side effect. If people have really severe renal impairment, you're going to want to avoid it. Again, that number needed to treat is 12, which is quite good for chronic disease. And it's thought that it likely reduces some of those chronic withdrawal symptoms, and has actions on glutamate and GABA, but we don't know 100% exactly how it works. Gabapentin, so this is off-label, and this can be used in two ways. So first of all, if you're using it for withdrawal management, you can quickly get up to that target dose of 1,800 milligrams 3 times a day. So you would start it for alcohol withdrawal, and then you would just continue it. If you're starting it off in someone who's not going through withdrawal, then you need to titrate it up more slowly, usually 300 milligrams, increasing by another 300 milligrams every 3 or 4 days, or every 4 to 7, depending on how that person's tolerating it. There are some individuals who sometimes will overuse it or abuse it, so you do have to be cautious in who you choose to prescribe it to. And again, sorry, and then there's topiramate. So again, this is off-label use. Topiramate's an anticonvulsant, so it can be used for seizures. It's also used as a medication in mental health, for mental health conditions at times. And I have some patients who've used this who've had good effect. Usually it's not one of the first or second line medications, just because of how many different side effects you can see. There's quite a large number of side effects compared to other medications. One important contraindication is individuals who are pregnant or planning to become pregnant. And then disulfiram, or the other name for this was antabuse. So this is basically an aversive agent. It blocks aldehyde dehydrogenase. And what happens is you have a toxic buildup of acetaldehyde. And that's, the person will flush, they'll become tachycardic, shortness of breath, nausea, vomiting, headache. And I think on the product monograph, it even says, risk of death. So this isn't something that you should give to someone who isn't sure if they want to stop drinking. This is for someone who's very committed to not drinking. I have used it in a fair number of patients. Usually it's individuals who are very committed to not drinking. Some of them will take it all the time. Some of them will take it in particular situations, such as vacation, where they're afraid that they might drink. I find it works well in people who are anxious, because they're very, very fearful of what would happen if they ever drank while they're on the medication. I would not prescribe it to anybody who has a tendency to be impulsive, because there would be that risk of them taking it with alcohol. So with all of these medications, the goals really are to decrease the number of drinking days, decrease the number of drinks on those heavy drinking days, and decrease their overall harms or consequences to their overall health. And so when using these medications, it's not just a matter of just prescribing them, but it's also talking to the patient about their goals, what they want their drinking to look like, choosing the medication somewhat based on what those goals are, and trying to get them functioning so that life is matching what those goals are. So just to finish up, so alcohol use is common and has very significant cost impacts compared to other substances. We have screening tools we can use to help guide our interventions. The low-risk drinking guidelines provide an important educational tool for at-risk drinkers, and this is something that all healthcare providers should be using and providing feedback to individuals who drink alcohol. Alcohol withdrawal may be life-threatening, and we should be assessing that risk, and that should guide our treatment plan and setting. And all individuals with alcohol use disorder should be offered alcohol relapse prevention medication in addition to psychosocial treatment. And I apologize, I did not get a chance to speak specifically to psychosocial treatment, but I think Dr. Martel earlier spoke about some of the different interventions, as did Dr. Fraser. And we'll leave the questions to the panel.
Thank you so much. Dr. Martel was right. Virtual format really lends itself to staying on time. So next, I'm going to speak about sedative-hypnotic use disorder, which follows nicely with alcohol use disorder, because basically these are alcohol in pill form. There's a lot of similarities. So we're going to talk a little bit about the epidemiology of sedative-hypnotic use disorder, including the fact that there's been an escalation in prescribing practices, outline when and why the use of sedative hypnotics may be of concern and problematic, but also when they might be useful, and review the management and treatment approach to individuals with physiological dependence on sedative hypnotics. So in the 60s or the 70s, this was actually even more problematic than it is now. Sedative hypnotics were handed out sort of like Pez, targeting particularly women, and advertising sort of targeted this in the medical community, using these medications to address anxiety, stress, dysphoria, really, being targeting housewives that were stressed by, the understandable complexity of running a household, but I suspect also perhaps some of the tedium of feeling rather unfulfilled, because perhaps they were much more able to accomplish significantly more things, but because of society at the time were unable to do so. So it was really problematic, not just benzodiazepines, but also barbiturates and quaaludes. I haven't seen quaaludes since 1998, but if you want to see quaaludes, I guess you're going to have to go to Mexico. So benzodiazepines, mechanism of action. I always sort of think of GABA and glutamate as sort of like the brakes and the gas of the automobile. So the GABA is the brake, and the glutamate is the gas. And what happens in withdrawal and things like that is they get out of whack, so that there's all gas, no brakes. And what happens with benzodiazepines is they help increase the brake, which if you're anxious or you're having neuronal hyperactivity, whether for whatever reason, it settles that down. And so people really, really like these medications for the most part. Occasionally people have paradoxical reactions, and so they don't like them so much. But the vast majority of people find them quite appealing, and that increases their risk of abuse and people asking for them. So at the end of today, there'll be a quiz, and you'll be asked to replicate this picture and draw the benzodiazepine receptor. So memorize it quickly. I'm just kidding, that won't in fact be the case. One of the things that's useful to know, particularly if you're working in an emergency room setting, is flumazenil is sort of the naloxone or naltrexone of benzodiazepines. So it reverses benzodiazepine overdoses. That can be useful even in anesthesia, if you've given someone perhaps a little too much Versed and you need to back things off quickly. It's useful to be aware of. So benzodiazepines have a number of therapeutic effects, including acting as an anticonvulsant, particularly acutely, a muscle relaxant, amnesia with sedation. So, if you're going to reset my dislocated shoulder, I would prefer that you give me some midazolam so that I don't remember the experience. Alcohol withdrawal, we just talked about, widely used for insomnia, which is not necessarily so bad if it's short term, but it usually isn't short term. It's usually long term, and then it becomes problematic. And then certainly we use them in emergency room and in psychiatry for acute agitation. Rarely, some people will have a paradoxical reaction where the agitation in fact becomes worse. because they perhaps become disinhibited. So you have to be cognizant of that. We're all aware of the increased prescribing rates of opioids, and it's really been problematic in North America. What people are less cognizant of is that that increase in prescribing rates has been mirrored in benzodiazepines and also psychostimulants. North Americans have a real fondness for prescription medications, and we sort of have a bit of a mindset that whatever physiological or psychological distress I may be experiencing, there should be a pharmacological remedy to that, and we feel entitled to that. So it's problematic. There's a wide variety of benzodiazepines. Some of them are more popular on the street than others. Alprazolam in the last 5 years has become super problematic. I don't know what it's like in your particular area, but in my practice in Montreal, it's really become a major concern. And one of the biggest issues is not alprazolam in and of itself, but it's some fellow in his basement making something that resembles alprazolam in his bathtub, but it actually contains all sorts of other things, including fentanyl. And so someone who's opioid naive takes something that they think is a benzodiazepine, but in fact it is a very powerful opioid, and that tends to end with potentially death. So all of these are potentially useful. Alprazolam is also designed perfectly to be addictive because it's fast on, fast off. I really, really wish it would just disappear. Past year use of sedatives and tranquilizers in Canada. So the general population up to 9%, youth 4%, adults 10%, and seniors, which is really of concern because we know that there's issues with cognition, potentials for falls, and the typical picture is someone is a little bit confused, they fall, they break their hip, and then often that does not end well. Women are more likely to prescribe it than men. Okay. So they're really effective for severe acute anxiety. And I think, many of us have experienced severe acute anxiety at different times. A couple of weeks ago, I was in the dentist's chair and it wasn't going terribly well. And I asked the dentist if she had any sublingual Ativan because I really felt that that would be helpful. She did not, so we sort of had to tough it out. But gosh, it would have been helpful in the moment. What's more problematic is when these things are prescribed longer term. Benzodiazepines are not the first line treatment for any chronic anxiety disorder. It's super important to remember that. But there are certainly cases where we manage people on long-term benzodiazepines when other things have failed. Sometimes it's sort of a harm reduction approach. And sometimes they don't get into problems. Sometimes the harms of benzodiazepines are overestimated. So it really is an individual case by case, but you don't want it to be the first thing you try. In particular, panic disorder and social phobia tend to often be prescribed these things. And sometimes it can be a really useful adjunct of depression, particularly in the short term for agitated depression, bipolar disorder, particularly in the manic phase to help try to bring them back down, as well as agitated psychosis that we see in schizophrenia. Usually, we're seeing people to come off of benzodiazepines, what we call deprescribing, not because they're addicted in the traditional sense. Usually they're taking it exactly as prescribed, as has been prescribed for a long period of time. And there's this sort of iatrogenic physiological dependence. but they can't stop because they're physiologically dependent. So there are benefits to tapering. Sometimes it's the patient that initiates, I'd like to come off this medication. Often it's a new physician who suggests, wow, you've been on this for 30 years. I'm getting concerned. Maybe it's time we should take that away because you're getting older and there's going to be problems. And certainly usually I detoxify people in the context of being in hospital because they're more severe cases and they failed long-term tapering as outpatient. But it really is quite remarkable to take it off them. And you see this veil sort of lifting, and all of a sudden they're like present back in the world again. And their family members is like, oh my gosh, that's we haven't seen this person in 10 years. And they begin to realize, wow, there are colors in the world, and it's really very rewarding to see. And they come alive. So that's certainly something we observe. You have to remember, however, that taking people off these medications is physiologically stressful. And you have to take that into account, particularly if they have comorbid medical conditions, and particularly if they perhaps have either current or past comorbid psychiatric conditions. So sometimes that physiological stress causes an exacerbation of those things. I'm not sure why my headers have all disappeared, but they have. So the acute effects of benzodiazepines is sedation. The concern, of course, is decreased respiratory drive. And when they're mixed, particularly with other medications that are potentially respiratory depressants, sometimes there's a synergistic effect where the benzodiazepine alone or the alcohol alone or the opioids alone wouldn't be particularly problematic. But in combination, you end up with severe respiratory depression and accidental overdose. And you sort of see this with young people that are experimenting, and they don't have an alcohol use disorder, and they don't have a benzodiazepine use disorder, but they're at a party and they've had a certain amount of alcohol, and then somebody's passing around pills, and they take some pills not knowing they're another respiratory depressant, and then they don't wake up in the morning. The chronic effects, decreased neurocognition, the physiological dependence, and then physiological dependence is normative. If any of us take long-term benzodiazepines, just like long-term coffee, you're going to develop physiological dependence. That in and of itself does not necessarily mean that you have an addictive disorder. Oh, finally, a header. So when might benzodiazepine use be problematic? So risk factors for benzodiazepine abuse. So particularly if there's comorbid substance use disorders, I certainly deal primarily with people with addictive disorders, and they often are demanding of long-term benzodiazepines as treatment for their other substance use disorders. And there's no evidence for that. And in fact, there's a ton of evidence that that would be harmful and that is contraindicated. Certainly in opioid substitution programs, benzodiazepines are contraindicated because of the risk of double respiratory depressant action. Psychiatric comorbidities, certainly you see people using these as a substitute for other forms of chemical coping. In my personality disorder program, it's kind of rare for me to get a referral of someone who's not on a benzodiazepine. And one of the goals of even though it's mainly a psychological therapy, one of the goals is to try and get off those sorts of medications, which probably increases the effectiveness of things like DBT. So risk evaluation and management strategy. So you want to assess how many of the risk factors are present. You want to be really clear with the patient as to what are the treatment goals. You want to be transparent about what your goals are. You want to balance that with what's acceptable to them. But sometimes, you know, the what they want and what's medically indicated may not be compatible. And so you have to, you know, explain that. You want to have a treatment agreement as to how we're going to approach the tapering, and then have a care plan that's carefully laid out. You're going to want to monitor them quite closely as they're going through this process. In particular, you know, just visiting with a physician or a nurse practitioner can be very helpful in terms of psychological support, enhancing their motivation, because what you're asking them to do is not an easy thing to do, particularly if they've been on these medications long term. And then you sort of have to have some contingency plans as to if things don't go well, where are we going to go from here? So sometimes you have to put a pause, sometimes you have to temporarily go back, and you have to be sort of cognizant that, you know, in your own mind, this is going to be a marathon. This isn't going to be a sprint, which is one of the advantages of doing it in hospital, is that you can accelerate the process because they have all kinds of medical supports in place, and does make it a bit easier. But of course, coming to hospital presents with its own risks and limitations. So you want to look at other sedating drugs that they may be on. So some of those may be prescription drugs like quetiapine or trazodone, yes, and some of them may be over the counter, like Benadryl. You want to look for respiratory and sleep problems, their age. Liver dysfunction is super important. If they're having liver issues, then they're going to struggle to metabolize some benzodiazepines like diazepam, and are probably better off with things like lorazepam and oxazepam that are gentler on the liver. Most people have some sort of comorbidity because obviously they were started on benzodiazepines for some reason, even if it might have been 3 decades ago. And if prescribing, we talked about that already, and the importance of following people closely and being very transparent about what you're doing. When you're so benzodiazepine withdrawal, basically what's happening is that those brakes that have been put on are going to be let up, and you're going to have a rebound neuronal hyperexcitability, which is unpleasant. People do not like this. They feel anxious, they feel distressed, they have insomnia. Very, very similar picture to alcohol withdrawal. And, you know, it's rare, but, you know, probably once a year, I have somebody come in for severe benzodiazepine use disorder, and despite our best efforts, ends up in ICU for a short period of time with severe delirium. So acute syndrome for the shorter actor benzodiazepines is 3 to 7 days. My experience is it's usually longer, because usually people have been on it for quite some time, and it's usually closer to 14 days. And then there's this concept of protracted withdrawal, which I've seen a few times, but I don't see it a lot. But occasionally I've seen 1 or 2 people where after a year they have these sort of mild withdrawal symptoms that are gradually dissipating, but extremely slowly. So withdrawal symptoms look very, very similar to alcohol. And the concern, of course, is that they may have seizures, they may develop a delirium, and that's what we're most concerned about in terms of safety. But in terms of success of actually coming off, the better you manage the withdrawal, the higher the likelihood that you're going to have a successful outcome. So factors influencing severity of benzodiazepine withdrawal, how long they've been on the medication, how high the dose is. So for me, I think the record of diazepam is 300 milligrams daily, which is, I guess, what you get. I don't practice veterinary medicine, but probably what you give an elephant, I guess. Um, and that was a physician that was taking that. So that's not something you can do in 5 to 7 days. The drug half-life, the individual personality style, so particularly people's ability to be resilient with discomfort, and then sort of the expectations of the patient and the physician. So oftentimes patients come with a lot of anticipatory anxiety because they've tried this before, or they've run out of medication and gone quote unquote cold turkey, and they're anticipating that like they're going to suffer terribly, and they're sort of predisposed because they're anticipating discomfort. So with the higher doses, you may want to consider it being in a hospital setting. It's real on an outpatient basis. It really depends on the patient and their characteristics. With my patients with borderline personality disorders, I don't think I've ever been able to do it in a month. I don't think I've ever tried to do it in a month. It's much more likely to be 3 months. And for some of patients, it's actually, we map out a 12-month process, recognizing that this is going to be a very long process. And that's okay. If somebody's been on benzodiazepine for 30 years, if it takes you 12 months to get them off it, that's not the end of the world. There's no prize for, it's not like the 100-yard dash. There's no prize for who's ever the fastest. So this is just looking at the characteristics as well as the conversion. So usually with the short acting, we want to switch them to a longer acting benzodiazepine, most often diazepam. Sometimes with the medium action or the longer acting, we may just keep them on the medication that they're on and work from that. One of the advantages of diazepam, I'm not an expert on all the benzodiazepines, but diazepam comes in liquid. And I've had some patients that are so severe and so somatic in their reaction to withdrawal that literally we're reducing 1 milligram at a time at the lower levels, and having that option of liquid format can be very helpful. Plus, you can blind the dose so they're not aware exactly of what you're doing. And you make that clear, we're going to blind the dose because you have so much anticipatory anxiety. This is looking at the same thing. So the treatment agreement is really important. Some people, this is verbal, many people it's written, and then you keep revisiting it. But you're going to have to be aware that you're going to have flexibility about this, and you're going to have to adjust it as you move forward. You're going to want to follow them closely. In particular, you're going to be concerned about the possibility of quote unquote addiction substitution. So yes, they're reducing their use of benzodiazepine, but their alcohol consumption is going up, or their cannabis consumption is going up. And the goal obviously isn't to trade one problematic substance for another. Helping patients journal is very helpful because it gives them a sense of control. CBT, we're going to talk about that in a moment. Physical exercise, relaxation techniques, sleep hygiene, all of these things can be very helpful. There's good resources available. I just want, where's my thing? Oh yeah, so I just want to jump ahead to this. So this is a really invaluable resource, and it's a series called Treatments That Work. And there's 2 volumes for each thing. This is stopping anxiety medication, but they also have these resources for hoarding disorder, for adult ADHD, for drug and alcohol abuse, almost anything you can think of, gambling disorder, smoking cessation without weight gain, super helpful. And so the thing is, you got to make sure they get the right book. So there's the workbook, which is what you want the patient to get. And it comes in Kindle format, but I don't like Kindle format because you can't write. So try to get them to buy the paper form, because there's exercises that you do, and they're much more effective if you actually do them pen to paper. And then there's a therapist guide. So oftentimes when I see patients, I know that their access to evidence-based interventions isn't great, but maybe they do have somebody that's working with them. And so I'll recommend that this be sort of the format of the therapy. And then I know they have some semblance of evidence-based intervention. So, so just like Dr. Willows was talking about, I use a lot of gabapentin. Don't use much carbamazepine, although you certainly can. The problem with carbamazepine is it interacts with so many other medications. Gabapentin tends to be very well tolerated. And basically with anticonvulsants, you know, with benzodiazepine withdrawal and alcohol withdrawal, you have this neuronal hyperexcitability. Ultimate neuronal hyperexcitability is a seizure. And so these anticonvulsants settle those down. And it can be very, very helpful for people. Also, if there's an underlying anxiety disorder, you may also be addressing that as well. And if there is an underlying anxiety disorder or mood disorder, you're going to want to come up with a plan as to how you're going to treat that in a non-benzodiazepine manner, and do a lot of psychoeducation around. Unlike benzodiazepines, SSRIs are going to take 3 or 4 weeks before you see some effectiveness. That's not instantaneous. So basic principles, and really these patients need a lot of support, a lot of validation about how difficult this is. You can be very genuine about that, because it really is tremendously difficult. They want to avoid caffeine, because that's going to increase their neuronal hyperexcitability. They're going to want to avoid alcohol because of what we talked about earlier. And the more active they can be to burn off some of that is certainly helpful. We talked about that. So here are some resources that can be helpful for you that I would suggest you look at if you want more information. And deprescribing.org is very helpful, and sort of gives you an algorithm how to approach these things. And that's certainly worth looking at as well. References. And I've finished with 2 minutes to spare, so I'm pleased with myself. That's it.
Thank you very much, Dr. Fraser. It was a very, very useful and practical talk. We're now going to move on to talk on cannabis. And Dr. Selene Etches is going to give us this talk. She is a child and adolescent psychiatrist at the IWK Health Center and an assistant professor of psychiatry at Dalhousie University, Halifax, Nova Scotia. She obtained her MD at the University of Toronto, her psychiatry degree at Dalhousie University, and completed further fellowship training in child and adolescent psychiatry at the Centre for Addiction and Mental Health in Toronto. Her time is split between working as an inpatient consultant liaison psychiatrist and as physician lead of the Concurrent Disorders Specific Care Clinic at the IWK. Welcome, Dr. Etches.
Thank you very much. It's a pleasure to be here. Welcome everyone across Canada, and perhaps be.
Yeah.
I'm here now. I have no conflicts. I'm just testing this, how to go through. There we go. Okay. There. So we're going to talk a lot about cannabis today, which I think is one of the most prevalent of substances used in Canada, and particularly concerning for adolescents, which is what I work with. So the first thing we're actually going to talk about is our body's own endocannabinoid system. And it's a really important system because it actually regulates the actions of neurotransmitters. And it's involved in so many roles of thinking, emotions, and memory. And why we talk about it particularly in that adolescent period where 50% of your brain is developing between the ages of 13 to 24 is that our own endocannabinoids really guide that process of brain development and brain maturation. So when, of course, when we get activated with adolescence, because when you flood these with exogenous cannabinoids, we don't know in which way this neuronal migration is going to happen as these kind of gatekeepers of what we're doing. And when we talk about cannabis itself, it's a really good idea to know a bit about the substances that people are using. And cannabis is very interesting. And we see this in all the cannabis lobbies because it does have a lot of medicinal properties and a lot of really exciting things that can come out of cannabis. And partly because it has over 500 compounds and 80 plus are cannabinoids. And there are a lot of psychoactive properties of these. Of course, we know about THC. That's probably the chief cannabinoid, which is a partial agonist to the CB1 receptor. And another one that's getting a lot of play lately is cannabidiol, CBD. So the THC and the CBD are the biggest ones, but there are a lot of others that are psychoactive as well that we really know very little about. But it's important to ask people when you're doing a cannabis use history, how much THC is in the cannabis you're using? Because sometimes they'll say, okay, about 18%, right? And that's the kind of typical, what you'd find in the liquor store or probably on the street, 18 to 24, 28%. Cannabis in nature, though, is about 4 to 6%. So it's useful to know what they're doing, whereas we'll talk a little bit about shatter and dabs. There you're looking more at even, up to 90%. So you do want to ask them, what's the THC content? What's the CBD ratio of what you're using? And then if they don't know, well, that automatically even builds that discrepancy in that motivational interviewing approach, right? Like, oh, you don't? Oh, okay, right? That maybe there's more to this than just I'm smoking some weed. There's a lot of effects of cannabis. So all the little yellow sites are where it's binding in the brain. So you can see everywhere that it's acting, of course, in that reward pathway of the nucleus accumbens, the universal addiction site, but also in terms of vision, coordination, really important when we look at its effects on driving, in terms of your movement, feeling really slowed down, your judgment. And you have this real distortion of time perception, which is important. A little bit of increased heart rate, important when we're talking about the risk for myocardial infarction, respirate, a little bit of orthostatic hypotension. You've got those red eyes. So if they're coming into your office and running to the bathroom to do Visine first, that's maybe a clue. And then that appetite increase. Now, I will say that a majority of adolescents and probably adults as well, but the majority of adolescents, particularly out east where I am, mix it with nicotine. And so they use it in the form of poppers. And one of the benefits of that for them, well, one, they do it primarily to get that head rush feeling. But the other part is you can use less cannabis, but also not get that appetite increase. So for a lot of people who don't want to gain weight, get the munchies, that nicotine reduces that risk. These are Canada's lower risk cannabis use guidelines. These came out of CAMH with the advent of cannabis legalization. So we're going to kind of go through them one by one. The first one is difficult, right? When you're working with people, just don't use, right? Some people may respond to that when you have that physician or that healthcare provider lens. They know that you're invested in their well-being. You counseling in that way might be helpful, but really these guidelines is a harm reduction model. We're really trying to get people to use less, to delay their onset of use, and to use in a safer fashion. What we can see from here is that this is the Canadian Cannabis Survey from 2020. And you can see that from 2019 to 2020, there's really kind of stable use, although a more recent report out of the pandemic showed that people were using cannabis more often, perhaps not surprisingly. But you can see also this kind of curve that this is the highest peak of this is really between 16 to 24 years, the frequency, the regularity, and then it really kind of does decrease. And most people stop. And this is true for all substance use disorders, right? That be even people, it is a disease of adolescence. Addiction is a disease of adolescence. It's a neurodevelopmental learning behavioral disorder that has its roots in adolescence. And perhaps we could even go back from that and say it often has its roots in early childhood trauma, right? But it has its roots in adolescence. And even if you have a lot of risk factors and you're using really heavily, only about 1/3 of people who are using heavily in adolescence go on to develop an adult addiction disorder. So most people use really, really heavily and then fade off. The challenge is again, like I said, this is a time of really intense brain development. So to have this group be such a high users of cannabis is concerning, and we do get a little activated about it. So when we talk about addiction, it's 1 in 10, so 1 in 10 people who ever use cannabis, but of course that goes up to 1 in 6 who start in adolescence. And again, it's a neurodevelopmental learning pathway, right? And it goes up even further, of course, to those who use daily. So 1/4 or 1/2 of those who use daily. And you can see on that graph on the right that cannabis is probably the highest substance use disorder. This is kind of illicit, so you're not going to see the alcohol and nicotine, which are still, of course, higher. So one of the biggest recommendations from those cannabis low risk guidelines was to just try to delay the age of your first use. We know that early age of use is a big predictor for later addiction. So it's just delay the use. Primarily, please don't try to use this before the age of 16. And so youth often do respond to discussions about neurobiology. They love to learn the brain. Here in Halifax, we have a group that we run, and one entire session is on the neurobiology of addiction and of cannabis and other substances on the brain. And they do really love that. And they have all sorts of discussions. And then they come in afterwards and they're like, Dr. Etches, my dopamine was activated in this craving time, you know, and we all clap, and it's really great. So they do respond to that, but our biggest factor that we're really trying to do from a harm reduction model is just delay when you start. It's not totally working. As you can see from this graph, daily cannabis use is more common amongst 12th graders than nicotine. So we've kind of really done a great job with the public health education about nicotine. That is going down, although unfortunately vaping is going up. But overall daily cannabis use is going up among youths. And so, you know, the challenge is that we often, as healthcare providers and as governments, we say, okay, what we need to do then, this is so risky and we want them to stop. So let's just cancel them, get our finger out and say, don't use them, here's all the risks, right? And this is what government campaigns do. And they look at graphs like this, which are really important to say, well, when people know about the risks of things, they use less. And when they perceive something as not as risky, they use more. And that is true. And that is a risk factor. The challenge is not to then only use that as your only intervention, to not just talk about the risks, because then you're missing all the other risks and you're missing all the other protective factors. And when you're working with people with substance use disorders, you really want to spend about 80% of your time really understanding their protective factors and strengthening them, and 20% of the time on your risk factors and mitigating the risk factors. Because of course, it's always easier to build on a strength than it is to create something out of nothing for a risk. And yet what we do, unfortunately, in healthcare is we spend so much time just talking, don't do this, it's so risky, it's so bad, don't you know about this? And we actually often push people away. So back to cannabis. There are really two forms, and so you can ask people about this in your substance use histories as well. There's cannabis sativa, which is more stimulating, more hallucinogenic, higher THC to CBC ratio, often kind of more daytime use. If you're a chronic cannabis user, you might be using that to kind of stimulate you in the morning. And then there's indica, which people say gives you more of kind of a body high. You feel very calm. They use it at night, maybe a little bit lower THC to CBD. So you might tell people from a harm reduction perspective, like, look, maybe you could use a little less THC in your cannabis. Maybe you could switch to the indica strain, try to pick those ones. The reality is, though, they've been so interbred that you're not really getting particular strains, but you could make them, again, more aware. Like, look, there are negative effects to this. What about trying a different strain? And that builds the discrepancy. I haven't unfortunately been able to find how THC has even been climbing from 2015, a graph. So I'm still looking for that if everyone can find that. But what we know, it's just gone up and up and up. So since 1995, there was a 212% increase in THC content of available cannabis in the community. And now when we bring in this advent of shatter and dabs, it's even gone even further. So that's why I think in large part, we're seeing a lot more mental health complaints among people as well. The other thing I want to draw your attention to is the synthetic cannabinoids, and to include that in your cannabis use history. To ask, are you using any synthetic cannabinoids? Any cannabis that seem to come out of little foil packets that might be called K2 or Spice or Moon Rocks. And why this is important is because they are research chemicals that were originally developed in Israel to look at our body's own endocannabinoid system that we talked about at the start. And they're sprayed on just out of a canister on some plants, and those plants might have psychoactive properties of their own. It is not cannabis. There is no cannabidiol in it, and cannabidiol may be anti-anxiety and antipsychotic, so there's no of that kind of mitigating property. And also, unlike THC, which is a partial agonist at the CB1 receptor, they are super agonists. So they can cause quite significant disruption to both mental health and physical state. So if you've got someone and you're suspicious, ask this on the history. If they come in and they have profound hypertension, or you're seeing a myocardial infarction in a young male, or they're seizing, or they have this like kind of treatment-resistant psychosis that lasts sometimes months, maybe ask. Although I will say it's difficult. Often, sometimes people don't know, and it's not detected in your standard urine drug screen that you might send. So you need to ask, please include synthetic panel. And then your lab may or may not do that. So it's just something to keep in mind when you're doing your cannabis history. In terms of how cannabis is used, this is something else you want to be asking about. In the bong, people think sometimes the bong is safer. It is not safer. It just cools down the smoke. So you often actually use more cannabis because you don't get that discomfort feeling that the joints do. In vape pens, in pipes, edibles. Edibles are important to think about because some people don't realize the delay of onset is kind of delayed a bit. So you want to counsel people on that. Just because you're a 2 gram a day smoker doesn't mean you can just eat 4 cannabis brownies. The other thing to watch for with the edibles is the dose. The dose at many dispensaries or liquor stores or wherever you're getting it from is 1 brownie typically is 4 doses, but no, who eats, a quarter of a brownie? Nobody. The other risk with these is that you really want to counsel people, if they're using edibles, please keep them away from children. They look really fun. And since cannabis has been legalized in certain states, there's been a corresponding spike in admissions to pediatric hospitals for cannabis intoxication. And certainly we've seen that here at our Children's Hospital in Halifax. Gummies, Pop-Tarts, they look pretty attractive and almost indistinguishable. So in Canada, there's kind of real packaging. There was a lobby to not allow this to happen, but still the gummies are gummies, brownies are brownies, lollipops are lollipops. So it's good to keep them away. Just wanted to highlight the dabbing practice, the shatter and the wax. These use a different type of system to use in a nail or a rig, it's called. It's a dangerous process to make. You take butane to extract some of the cannabis oils, and you can lead to explosions in your communities. It's good to ask. You'd be surprised when you asked how many adolescents are using dabs or shatter or wax at least once or twice. They don't seem to use it. I've only had 2 patients who this is their preferred method, simply because it's very, very expensive. So it's more kind of, the kids view it kind of as a party thing, or a group of them gets together, pools their money and gets this. But the reality is sometimes, as I said, up to 90% THC. So you're looking at sometimes very profound mental health effects, and something to include in your history. The other thing that I get a lot of questions about, and I've been seeing increasingly over the past number of years, particularly in adolescent females, is this cannabinoid hyperemesis syndrome. So something definitely to think about when someone comes in and they're saying, I just can't stop vomiting. I have this kind of periumbilical kind of colicky abdominal pain. And kind of pathognomonic of the condition is this And then I go in the shower or I have a hot bath and it kind of really helps. Now you do not need the hot bath or shower to have this syndrome. So if they don't get any relief from hot showers, that doesn't mean they don't have it. And it's an interesting syndrome because really we use cannabis, as you know, to be kind of an antiemetic. So the thought is that perhaps over time with chronic daily high THC use, you get kind of a pro-emetic effect. And it's incredibly challenging to treat because the treatment is really abstinent for cannabis, but not just for a day or a week. You might need up to 3 months to really get effect. So this is really challenging to ask people to just stop for that. Other treatments that are possible for it are some capsaicin cream. So you can get this from the pharmacies. It's really red peppered cream. They'll formulate it up, or they just often have it in tubes already, and they can rub it on their stomach, and that can help the kind of abdominal pain. There is some evidence for when they come into the hospital for IV Haldol, or sometimes people are using olanzapine. Not IV, of course, but some olanzapine just to help. The regular kind of anti-nauseants like ondansetron don't seem to work as well, but it's really challenging. And we often get adolescents who need to come up to hospital and actually get IV rehydration. And there are reports of acute kidney injury from this prolonged dehydration, but also perhaps the hot baths. The other thing I just want to highlight, because it's top of my mind right now, is don't forget, if you are rehydrating, to think about Wernicke's. Even in young people, because if they've been vomiting for a very long time and they're not having good nutritional intake, it only takes about 3 to 4 weeks for your thiamine stores to be depleted. And so you definitely don't want to just rehydrate them with some D5 without kind of looking for that, or perhaps just giving the thiamine. So it's a very challenging syndrome, and I have been seeing it increasingly frequently, which I don't know why that is. The other thing to think about is the respiratory effects, so chronic bronchitis. Not as much evidence linked to COPD or lung cancer, which cannabis advocates will proudly proclaim that it's not as bad. There are case reports of Aspergillus pneumonia, just contamination of your supply. So again, good to know your source. Just in general, harm reduction principles for addiction: have your SETI source, know where it comes from, be safe. Make sure it's not moldy. The other thing is the cardiovascular effects. And as I said at the beginning, it increases your heart rate. So if you've had an MI already, there's a 4 times increased risk that you will have another one in the hour after smoking cannabis. So perhaps something to counsel people who do have an MI history. There are reports of those kind of acute MIs and strokes, particularly again for synthetics. And a recent Canadian study that just came out, I think last month, recent cannabis use is associated with increased odds of history of MI actually in younger people. So the thought was that this was just older people, but that it's actually in younger people aged 18 to 44. The strength of that association increased with more frequent use of cannabis. So this is not benign on the heart, even if you're young and healthy. The other thing to counsel people on is driving. As you saw, it bounds to areas in your cerebellum. It decreases your reaction time. It decreases your sense of time perception. You kind of accommodate for this. People with cannabis who are driving know that they're impaired, so they slow down and they kind of maintain. So if you're ever on the road and you see someone driving quite slowly and steadily right in the middle of the road, you smell the cannabis from them, it's infuriating, then you know they're probably intoxicated. The challenge is that compensatory mechanism of slowing down, knowing that you're impaired, is really altered if you only have 1 glass of alcohol. So usually, you could still, I guess, technically drive after having 1 glass of alcohol. But if you use alcohol and cannabis, it's kind of this synergistic effect. So you lose that compensatory response to slow down with the cannabis. So really, there's no strict guidelines, but we kind of say, try not to drive for about, 8 hours after you've been intoxicated. Certainly don't drive while smoking a joint, although you certainly see that a lot. Edibles have that longer time in your body, so best not to drive at all. I will say this public health about driving high campaign does not seem to have registered almost at all with the youth I see. whereas the drinking campaigns have. It's very interesting when you look at these public health alcohol campaigns. Youth will say, like, I'd never drive drunk. Then they kind of say, well, I might be a passenger of someone who's driving drunk if I trust them. So, and then, but the will I drive high on cannabis, or will I be a passenger of driving with someone with cannabis? That's way, way down in terms of their risk perception. Let's talk a bit about mental health, because obviously as a child and adolescent psychiatrist, that's pretty much all I do. And we're going to go through the different forms of mental health. Okay, so cannabis-induced psychotic disorder. This is typically rare, quite quick, self-limiting, maybe a couple hours, maybe a few days, responds really well to treatment. They might present feeling like they're not real, the world around them is not real. They might have some hallucinations, often get very, very, very paranoid. So you say, are you getting really sketched out? They'll say yes. But, you know, a little bit of low dose, maybe a little quetiapine, maybe a little bit of Ativan, just reassurance, look, this is what you're going through. That clears very rapidly. It is still not a good thing. And I tell adolescents this all the time, look, most people don't get this. So the fact that you are means that something's with your brain and you want to avoid it. Please take a drug holiday for a while, or really cut down on your use, or really decrease your THC. This shouldn't be happening. And it means that something's a little bit more vulnerable in your brain. I don't want you to go on and develop another one, even if it cleared really quickly. And again, just to highlight, synthetic cannabinoid-induced psychosis does not clear quickly. Sometimes it is indistinguishable from schizophrenia. So it's just something to have in your differential of, could this be that? Why do we worry? Well, this is a pretty clear association that's only strengthened over time. It does seem that there's about a 4 to 5-fold increased risk of developing a psychotic disorder if you use cannabis heavily. And so this is where it's that challenge, well, what is heavy, right? If I go to a party and I have cannabis every Friday night with my friends, is that heavy? Or is it every day? Or is it multiple times a day? So that is hard to quantify. What we know is it's the more you use and the higher the THC, it's a much stronger association with developing a psychotic disorder. That risk even strengthens if you have that early age at first cannabis use, frequent daily use, that high potency cannabis, but also other risk factors for psychosis, like first degree relative, early childhood trauma, birth trauma, things like that. But what we really know, or what we're saying now in mental health, is that cannabis is viewed as a preventable risk factor for schizophrenia. And that if we can prevent, identify early, or treat a cannabis use disorder, particularly in those who have other risk factors for developing a psychotic disorder, we can really help mitigate that risk. And what we say very clearly is if siblings of people with psychosis, they shouldn't be using cannabis if they can at all avoid it, and those with really any family history of psychosis. Here's the probability of conversion from substance-induced psychosis to schizophrenia. So this is if you have a psychotic disorder on that substance, even if it clears quickly, you can see how high that is for cannabis compared to your other substances. So a really big risk factor that we take seriously, that we monitor. When we admit kids for a cannabis-induced psychotic disorder, we don't just say, oh, you're done, have a great life. We monitor them quite carefully. And we're really cautious, and we do a lot of psychoeducation and try to build on those protective factors that they have. So cannabis is the most commonly used illicit substance, though, in patients with schizophrenia, and it contributes directly to more hospitalizations and longer hospital stays. And we know that if they stop using, they have decreased positive symptoms, so those kind of delusions, hallucinations, disorganized thinking, improves their mood and anxiety. We also have less hospitalizations, more medication adherence, and decreased relapse. So it's important to not just give up on someone who has schizophrenia and say, well, you're using, that's all you have in life. Similar with nicotine. We do a very poor job in mental health treating concurrent substance use disorders. because I get a lot of questions about this, CBD and psychosis. There is a lot of emerging evidence and research going on using cannabidiol only for the treatment of psychotics. So a lot of potential emerging, a lot of 2 trials that have just come out, we don't have the results yet, and 2 active trials recruiting participants, and then some that seems to suggest that it actually works as well as an antipsychotic, not an antipsychotic we regularly use, amisulpride to be honest, but still, and then one that showed nothing. But so something that really is, so again, from a harm reduction perspective, if someone with schizophrenia is smoking a lot of cannabis, might be useful to say, how can we increase your CBD? The challenge with that, of course, is that it's hard to get CBD high weed because no one's really that interested in it. People really want the THC high, so that's where the demand is. The same correlation that is true for schizophrenia and cannabis is also true for bipolar disorder. So those who are using cannabis heavily often have an earlier age of onset of bipolar disorder, increased length and number of their episodes, more rapid cycling. So rapid cycling is when you typically have about 4 episodes a year of either POL, depression, or mania, more suicide, just more severe course of your illness if you're concurrently smoking cannabis. But if you can help people to stop smoking cannabis, they had similar outcomes to those who did not use cannabis, who also had bipolar disorder. So something, it makes a big difference. Depression as well. So people who use cannabis, and again, we're talking about that early, heavy, chronic use, they're more likely to develop depression. We know this. And it does appear to be young women particularly. And that may be because women's estrogen and young females as well, that depends on your endocannabinoid system functioning well. So those estrogen effects that kind of interacts with the endocannabinoid system, flood that with those exogenous cannabinoids, you're just disturbing that. So you're getting these really hormonal changes and more depression. Suicide as well. Suicide's a hard one, right? Because suicide is a really rare event, thank goodness. And it's so multifactorial that it's hard to say. It does seem that the more you smoke cannabis, the more risk you are to have that suicidal ideation and suicide attempts. Again, that kind of leaning back to, okay, under 15 is your key time. Recent study that just came out again looked at adults 18 to 34. And they did a very large study, and it was past year cannabis use disorder, daily cannabis use, and also just non-daily cannabis, but continued cannabis use were associated with a higher past year SI plan and attempt. And that's when they took out the confounders of major depression and things like that. And again, that women more than men, a greater signal. So definitely when you've got someone who's coming to you really depressed or suicidal, you really want to do a very comprehensive cannabis use history as well and see what you can do to change that. Anxiety is a tough one because people will come to you and say, well, I am smoking because it helps my anxiety. And in a way that is true. And I always say, yes, that is true when right in the moment, and that's where you're living. You are just living your life in the moment. And all our mindfulness stuff says to do that. It is really helping you. Your anxiety goes away. The problem is that over time, particularly again with those high THC, that chronic use, all that's happening is that your anxiety is building and building and building. Then you smoke, get your anxiety down, builds again. And then we also have that kind of mini withdrawal and massive withdrawal happening that we'll talk about in a minute. And that's causing more anxiety. So it's a real challenge, particularly because people who have that premorbid diagnosis of social anxiety disorder, it really helps with that. Cannabis can just be this relief initially for it. So it's kind of like how we correlate addiction with kind of an abusive relationship, right? There's these great highs and there's these such great lows, and you're trapped in this cycle of kind of escalating need and explosions and release and nightness. And it is a relationship. So it's really tough to break out of it. The other thing is PTSD, and we all know about PTSD for cannabis because Veterans Affairs actually pays for cannabis authorizations and pays for the cannabis for a lot of our veterans. But in fact, there's no evidence to suggest that it's helpful. And there's actually quite a lot of evidence to suggest that it might be quite harmful. When we look at the trials, cannabis use in PTSD is associated with increased symptoms, severity of the PTSD, more violent behavior, more other substance use, exacerbations of that kind of PTSD impairment in memory, concentration. So it's really not something you'd recommend at the present time for cannabis. Again, cannabis is hard, right? Because the THC is in so many different amounts. What's your CBD ratio? What about your other psychoactive chemicals? So, but right now, there's not enough to say, yes, this should be a treatment. The other thing we worry about is the cognitive effects of cannabis use in adolescence, because it does seem like this is impairment with decreased executive function and impulse control, decreased processing speed, decreased working memory, possible IQ decline, although that studies were challenging. So it's definitely got negative effects on the brain, particularly in adolescence. The other thing people will tell you is that, well, I use THC to get to sleep. I use cannabis to get to sleep. And this is also tough because, yes, THC has this kind of initial benefit of getting you to sleep. But over time, again, with that chronic daily use, you get actually a delayed sleep onset, disrupted circadian rhythm, a lot of daytime sleepiness that might actually be why we think of it as kind of amotivation, your lack of motivation, but they might actually just have this like residual sleepiness and these circadian phase delays. CBD is challenging too. In low doses, it may be more stimulating, but in moderate to high doses, it may be more sedating. You can see the need for more research on it because it definitely can help and it also hurts. So when we look at kind of our effects on mental health, we know there's a very high link with addiction, a medium link kind of with abnormal brain development, a medium thing with this kind of progression to other drugs. Schizophrenia, definitely more up there. I'd say bipolar as well, same as depression, anxiety. So a lot of really negative effects of using chronic cannabis. And then we want to look just briefly into our special populations. So some people do have a definite predisposition for more adverse effects. So those people who have that first degree relative or their own predisposition for psychosis. Those who have their own history of substance use disorder or genetic risk factors for that. Pregnant women, and of course, adolescents. A lot of people are using cannabis in pregnancy. It's viewed as natural, as a kind of antiemetic in a way that maybe diclexin isn't. It is the most frequently used substance in pregnancy. It crosses the placenta to the fetus. We know that. Usually these babies seem to be a bit smaller, although is that significantly smaller? They do have an increased risk of being in the NICU and a bit of lower birth weight. It also, cannabis is transferred into the breast milk. So there's a lot of great, there's actually 3 longitudinal studies. You can check out the SOGC, so the Society of Obstetrics and Gynecologists from Canada, if you want more research references on these. Or they have some really great pamphlets and videos, and they did a very big informational campaign recently. So one of the other things to really recommend to people, and I do this with my patients who have children, is to say, you know, look, cannabis smoke, even secondhand, is a risk factor for SIDS. You don't want to smoke in the house. You want to wash your clothes before you hold your baby. And so again, that kind of helps to kind of, well, is it worth it for me right now? And might decrease their use as well. So I probably impressed upon you, oh no, people are smoking too much. What do we do? Well, we have to treat. Right? We need more research to help. It's challenging being an addiction provider. I appreciate the fact that you are all here wanting to learn more about it. I would say it's a very challenging field because we don't have a ton of options. Yes, we can do all these great things that do work, like mindfulness and sleep and relaxation and therapy, but the reality is you do need a lot of adjunctive medication help and treatment programs and trained therapists, and it's hard to get that, and it's hard in a motivation-based illness to keep that going for people, especially when they have the stressors of everyday life or big stressors that obviously precipitate craving and relapse. And one of the biggest things that we don't treat well is cannabis withdrawal, and cannabis withdrawal can be really, really, really horrible. It's that kind of, you get very irritable and you have a really marked sleep difficulty, and you can feel very depressed and very restless, and you can get this abdominal pain that's really upsetting, and sweating and headache and fever and chills. And the other thing you can get that we often see is just this profound irritability, and often with associated aggression. So, but then when you smoke, it all immediately goes away. And this kind of rebound anxiety as well. So it's really, really tough. It's most intense in the first week. It actually peaks on day 4. So if you can get people past day 4 or 5, that's really helpful. The other thing to remember is that because people often use that nicotine and cannabis together in those poppers, they're having 2 withdrawals. So in addition to trying to treat the cannabis withdrawal, you might want to say, well, what about a nicotine inhaler or patch or gum or something else? How do we manage withdrawal? Well, the biggest thing is honestly sleep. And again, in addiction medicine, it's hard because any sleep medication obviously has inherent abuse and diversion potential. And when you're practicing any sort of medicine, let alone addiction medicine, you always want to evaluate the medications you're choosing and say, what is the inherent abuse and diversion potential of the medication that I'm providing? And a lot of our sleep ones have really high street value and really high abuse and addiction potential. But if you've got someone who's really motivated and really wants to stop, I would advise, you know what, probably some sleep medications for a really short term, maybe only a week, would be useful. So Zolpidem was used for 3 days. Improve sleep, doesn't improve other withdrawal symptoms, obviously doesn't improve craving for cannabis. I tend to use mirtazapine, to be honest, the most. Low dose mirtazapine, 7.5 to 15. Quetiapine, I don't use this. I put this in the study. I don't like the fact that quetiapine is used so often as a sleep aid, particularly immediate release. Immediate release has a lot of abuse potential. It's injectable. And in fact, there's other studies that show that quetiapine increases craving, but I thought I'd put it here because it was in a study and it did help sleep. I would never use 200 milligrams. I may in the next one just not do this because it's something I would never do. It's in a study, but so you feel you got to be complete, but I would never do that. So mirtazapine might be your best, or trazodone. The other thing is nabiximols can really help cannabis withdrawal. So that's where it's a treatment approved for multiple sclerosis, and you spray it in your nose. It's a kind of 1-to-1 ratio of THC and CBD. Really does seem to help. It's expensive though. I did the calculations. One box is 3 vials. It's about $700. So one vial is about $250, and one vial is 100 sprays. So you need 32 sprays per day about to manage the withdrawal. So one vial would last about 3 days. So $83 a day for nabiximols. Now, people might want to do that though, right? That might be covered by the drug plans. You just might want to do it out of pocket. The other thing I do think we need to think about though is when people come into hospital as involuntary patients, if they're mental health patients with involuntary admissions, we have an ethical responsibility to manage their withdrawal. And I think we need to think about this more in the psychiatric world of how are we doing this. It's not fair. It's very unethical to have people languishing in honestly torment. Cannabis withdrawal can be really horrific and not treat them. The other one is the cannabis agonist, cenabolone, and I have used this 1 milligram twice a day, and then you can increase to 3 to 4 milligrams twice a day as needed. And this might be, again, a short-term way to help manage the withdrawal, and there is evidence for that. Then what do you do? When you manage the acute withdrawal and now you've got this cannabis use disorder and you need to treat it. So the biggest thing is, you're trying to, like all addiction medicine, have you heard about today, you might not get at treating their cannabis use disorder by actively just addressing the cannabis. You might have to do it in a kind of circumferential, roundabout fashion by focusing on other domains of functioning. So that means, you might get them by their sexual health and helping get their chlamydia treated, or you might get it by just kind of doing motivational interviewing because you recognize they're pre-contemplative and that you have to do different treatment modality interventions, right? You might get it by focusing on a therapeutic horseback riding course, right? Whatever you do, you have to look at this and say, okay, there's more domains of functioning than just substance. Substance is one. So how do I get this person to engage with me? And how do I get them to work with me to know that I'm someone to be trusted and someone to be listened to? Because people aren't going to care at all what I know until they know that I care, right? So we have to do that first. So that's number one. Then medications, because we always want to know about medications. What do we got? So spoiler, not very much. There are studies and a lot of interest on rimonabant. So that is the CB1 inverse agonist that you might have heard of before for the obesity management. And when you use rimonabant, you smoke cannabis and you actually don't feel any positive effect at all. So it blocks any effects of it. So sounds great. But the problem is these people who in this study had marked dysphoria and actually marked suicidality. So the trial was actually stopped early because obviously that was not good. But interesting, maybe more could be done. Then we have the anticonvulsants. Don't bother with lithium, don't bother with divalproex. They've done studies, there's no effect of those. Now, gabapentin. There is some evidence for gabapentin, particularly in adolescents. So again, a lot of our treatments here come, and again, it's kind of nice and encouraging because again, it's a disease of adolescence, addiction. So if we intervene early, so there was a 12-week randomized control trial of 1,200 milligrams once a day, and you actually go up quite rapidly, you go up by 300 milligrams a day. So you're basically at your dose in 4 days. Definitely decreased use, decreased withdrawal, decreased craving, and improved sleep. So it's worth a try. Challenge with gabapentin though, TID dosing, right? But also high abuse potential. Actually is not allowed really in the prison system now, is kind of viewed as maybe should we be monitoring this. I have a lot, kids snort it, you can inject it, the highs are different for everybody. So some people say it's like MDMA, some people say it's like cannabis high, some people, particularly if you have a history of an opioid use disorder, you really want to avoid gabapentin. So it's a challenging one. You don't want to be given 3 months of things like this. You want to monitor it. You want to be maybe checking your diversions, doing your kind of red flags for misuse, but it can be really useful. And, you know, there is evidence for it in social anxiety and anxiety disorders. So it can be really helpful and it's definitely worth a try. The other one that's always worth a try is N-acetylcysteine, particularly in your adolescent or younger kind of under 25 population. That's 1,200 milligrams twice a day. There was a big randomized control trial that N-acetylcysteine plus contingency management was really helpful to help decrease cravings and use. Again, only in adolescents. They replicated the trial in adults, was not successful, but there was a trend towards significance in the younger age group. So it might be something about the adolescent brain. I honestly try to give every adolescent that I see N-acetylcysteine for any complaint, because it's kind of it's a glutamate cysteine exchange stabilizer. It's just really good for habits. We use it a lot in psychiatry for other things like trichotillomania and cutting and nail biting. It really has no side effects. It doesn't interfere with other medications. So your only limitation is adherence and cost, because it's not, you just basically get it from a health food store or on Amazon. So it's about $40 a month for that dose. And you just start it at 1,200 milligrams twice a day. There's a lot of interest in some other medication, oxytocin, a lot of interest in oxytocin addictions in general. That could be a whole other talk. When you think about oxytocin as that kind of attachment hormone, it's an interesting one to ponder, because if addiction is a disease of connection, how do we build connection? Some interest in varenicline, FAH inhibitors, some interest in naltrexone. I'm sure Dr. Williams talked about the value of naltrexone for alcohol use disorder. There is some possible evidence it might help in cannabis. There's also interest in CBD. And the one that you might not want to use, although it's hard to know, is venlafaxine. There was a little bit of a signal that maybe that increased cannabis cravings. So if you're choosing an antidepressant and they've never been on antidepressants before, maybe just don't jump to venlafaxine, but probably you wouldn't anyway, because it's not really your first line antidepressant for most people. I'm just going to talk very briefly, because I'm aware I don't have much time left, on CBD to manage cannabis withdrawal. There, a recent study came out. Cannabidiol 400 milligrams and 800 milligrams were safe and more efficacious than placebo in reducing cannabis use. People still use cannabis, but again, if we're approaching this in a harm reduction lens, abstinence is not our ultimate goal, or, you know, it's just a signpost on the way to abstinence. So harm reduction is great. So if people want to try that, that's fantastic. And if parents come to you and say, what if I buy my kids CBD? Well, they might just take your CBD and then also keep their money for their own weed, but it also might help. So as a harm reduction initiative, that's fine. So this is just a summary slide of this. So the targets that you're using for the withdrawal, and then your targets that you're using for cannabis use and relapse prevention. Not a lot, unfortunately, so it makes it tough. The other thing to really remember is assess for any concurrent mental health disorders. We want to do this in an integrated fashion. We want to treat our mental health and our addiction at the exact same time. And the other big challenge is, you know, there are therapeutic potentials for these medications, right? Neuropathic pain, spasticity in multiple sclerosis, dyskinesias in our late stage Parkinson's, increasing appetite, although not overall weight gain in HIV/AIDS, reducing chemotherapy-induced nausea and vomiting, although all our other treatments are much better. That should be about 4th line. And decreasing ocular pressure in glaucoma, although apparently in order to do that, you would have to be continually smoking cannabis every second of the day without stopping. So it might not be worth it. The other thing I just want to draw your attention to, it's not that like cannabis doesn't interact with things, both pharmacokinetically and pharmacodynamically. So particularly CBD, actually. So you want to be careful. I had one youth who was on the mirtazapine for another reason, switched his cannabis to only CBD and developed profound night sweats. And when we stopped the CBD, the night sweats went away. So it's possible that through that cytochrome P450 system, the CBD was interacting. So it's not benign to just give cannabis, and it's really important and challenging to honestly to work with cannabis providers, because oftentimes there's not that back and forth communication. So it really, I found it really behooves you to seek out if someone is, and find out if they're seeing a cannabis provider, and then really try to encourage that your patient to allow you to become part of the circle of care with that cannabis provider, because sometimes you don't know what they're getting. There are a lot of contraindications for a cannabis authorization for medical purposes. They're listed here. I think sometimes that's where you really want to work closely with the person who's authorizing it. If you are an addiction provider, or if you're working with the patient too, sometimes different stories are told, or different views are held. So it's just really good to communicate, right? So not a lot of evidence right now that cannabinoids are particularly effective for a lot of medical conditions, but the field is new, and the field has also been limited because it was viewed as a crime and it was illegal to do research. So it'll be an interesting new development in the future. And that's my time. And now it's Q&A. So thank you very much for your attention. Really appreciate it.
Thank you very much, Dr. Etches, for a very engaging and informative talk. I'm just going to ask all the participants if you'd like to put any questions that you might have for any of the speakers from either Block 1 or Block 2. So that was the biopsychosocial approaches to addiction, Dr. Fraser, assessment and diagnosis, screening, brief intervention, and referral to treatment that Dr. Martel shared with us. And then the talks on alcohol, sedatives, and cannabis. So I'll just give people a few minutes to put any questions that they might have for any of the speakers in the chat. And then we'll start addressing those questions. Okay, so we have a question for Dr. Fraser. Dr. Fraser mentioned, sorry, I know my questions are hopping around, mentioned that we are unlikely to start using long-acting naltrexone injections here in Canada, although it is elsewhere. Why is this? What is the barrier to use here in Canada?
So that's an excellent question and a source of personal frustration. But basically, it's just economics. The manufacturers have decided, and I'm sure they're probably right because they analyze these things to death. They've just decided that there's no economic benefit to providing that particular medication in Canada, and so they're not prepared to pursue it. So as a result, unfortunately, Canadians are left once again out in the cold.
Thank you, Dr. Fraser. There's another question for you here. Are you aware of any evidence-based treatments for amphetamine or stimulant use disorders?
So Dr. Crawford will probably touch on, or sorry, Crockford will probably touch on some of this afternoon in block 3. There isn't any evidence-based pharmacotherapy for addictive disorder, for stimulant use disorder, although there are things that we try, but currently there's no recommended pharmacotherapy. The mainstay continues to be psychosocial interventions, and in particular, contingency management was developed specifically to deal with the problem of methamphetamine in the southwestern United States. Sort of in simplistic terms, it's the idea that if addiction is Pavlovian conditioning, then we can reverse it and condition them to something else. And the idea is that when you present with a negative urine sample, you get a voucher, and usually it's cumulative in nature. And so the more repetitive negative urines that are provided, the increase in awards. And so you're reinforced for that particular behavior, and that's been shown to be quite effective. The problem with that is that it's not particularly politically palatable because it's perceived as paying people to not do drugs, which is a tough sell in some parts of the country. But it is unfortunately very effective. So it's not great that it gets perhaps the short shrift for political reasons and ideological reasons rather than scientific reasons.
Thank you. We actually have quite a few questions for you, Dr. Fraser. Any experience with navigating a benzo taper in a patient who has an alcohol use disorder as well?
Yes, although not usually as an outpatient, because typically what one often sees as an outpatient is as you taper off the benzodiazepine, there's simply a compensatory increase in alcohol consumption. So those are the sorts of patients that often need to be managed on an inpatient basis, where you can manage the withdrawal for both substances simultaneously.
Okay, along that same area, there was a question about how do you recommend managing acute benzodiazepine withdrawal in an ER setting? I saw a patient recently where staff used phenobarbital to avoid giving any further benzodiazepines. Are there any other options you would suggest?
Well, acutely, you could use anticonvulsants, and in particular, gabapentin. But I think you also sort of have to look at there's the short-term plan, but also the medium-term plan. So if this is somebody who's going right back on benzodiazepine for whatever reason, you may choose to treat their benzodiazepine withdrawal with a benzodiazepine. So I think it depends a lot on the bigger picture.
Okay, sorry, lots of questions about benzodiazepines. When a patient presents with opioid and benzodiazepine use disorder, is there a priority to treat one before the other? And how difficult is it to navigate opioid agonist therapy with concurrent benzodiazepine use?
Okay, so I'm going to answer this one, and then I'm going to suggest maybe we can jump around a little bit.
Absolutely. Sorry, Dr. Fraser. It's just a lot of interest in the benzodiazepines.
Well, that's good. I'm excited about that.
Yeah.
So, excellent question, because it's very, very challenging. And of course, the best practices for each is quite different. So for benzodiazepines, you're probably going to want to try for abstinence and to try and withdraw and discontinue the benzodiazepines entirely. Whereas with opioid use disorder, you're probably going to want to go with a substitution therapy, because that has by far the most robust evidence. So you're going to want to put them on something like methadone or buprenorphine. And so you're going to probably want to tackle those simultaneously, trying to substitute to a safer opioid substitution agent, while at the same time trying to taper down their benzodiazepine.
Sorry, Dr. Mertel, did you want to add something there?
Yeah, there's just a little nuance to that question in that the scenario comes up with patients seeking withdrawal management repeatedly through emergency departments for alcohol use disorder, and then the attending ER physician becoming concerned that all they're really doing is feeding a new benzodiazepine use disorder, people rapidly cycling over and over again. And there are scenarios where we look at alternatives to benzodiazepines for that reason. But with that level of complexity, I think you're reaching out to a medical withdrawal management unit and an addiction medicine specialist to guide you, because those are quite complex. And what I've seen done, of course, is just freshly treating the withdrawal with something like gabapentin instead of the benzo. But as you had illustrated, Melanie, that has its own issues, especially if it's used as like ongoing medication.
Absolutely. Absolutely. That's probably one of the biggest mistakes I see is kind of that 30-day prescription of large amounts of benzos to be taken as needed. And instead they're taking regularly and more plus alcohol, and then a new problem makes it much more complicated. There's a question around cannabis. The question is to Dr. Etches. You spoke about using zolpidem and mirtazapine for the insomnia related to cannabis. What about options for treating anxiety in people who are using cannabis?
Treating
Anxiety.
Treating anxiety in people with cannabis use disorder?
Yeah. Like I think probably it's getting at the anxiety that they experience as part of the withdrawal.
Oh, I see. Well, I mean, mirtazapine is probably not going to treat an underlying anxiety disorder per se. If you have, a comorbid generalized anxiety or a panic disorder or a obsessive compulsive or any sort of social anxiety in that acute withdrawal phase, because it just will take longer, but that kind of histaminergic properties of mirtazapine will kind of take the edge off things probably for you. Zolpidem, like zopiclone or zolpidem, they have their own inherent risks too, being the Z drugs. So I don't find them as helpful for that anxiety piece of withdrawal. I would definitely not be giving anything like a benzo, though, in the setting of a cannabis withdrawal. That would be very contraindicated. You're probably just making more issues for yourself and for the patient going forward. But it's a good point that if someone does have a concurrent, actually underlying anxiety disorder, you want to be addressing that and treating that with maybe not even medications, as our therapy options are much better for anxiety if they can buy in and do the work.
Now, there's another question about cannabis. I'm not sure if I'm understanding it correctly. What is the place of nabilone in the prevention of falls with cannabis? Evidence, practical advantages, disadvantages.
I'm not sure about that question for falls.
Yeah.
So I apologize. I don't know. That
Oh,
might be.
I'm guessing it perhaps is referring to relapse.
Okay. Okay. Thank you. Thank you.
Probably
Thank
if I
you.
spoke French, and my sincere
Thank you.
apologies. Yeah, no evidence for that. The real study was in the treatment of acute withdrawal. So no real trials on that yet. And I don't know if they would. No, my fault, not yours.
No problem. So there's another question about the place of antipsychotics in the management of delirium tremens, in addition to benzodiazepines to treat confusion and hallucinations. Yes, I mean, I don't work in ICU, and my whole job is in preventing delirium tremens from ever occurring. But I believe it is used in addition to the benzodiazepines, but ultimately you do need to make sure the benzodiazepines are on board to treat the withdrawal. Okay, any other questions that we've missed? Or anything else that anybody from the panel wants to add from their talk or from some of the questions that have come up. I'll just give it that silence as Dr. Martel suggested. Just
I'm waiting for Dave's cat.
I'm surprised nobody has posed any kind of question yet about specifically about safe supply initiatives.
Well, we haven't gotten to the opioid talks yet,
Yeah.
so maybe
Well,
it's. Oh, here's another question. Let me just make sure I'm getting it right. Absence for all. Absence-based or absence goal treatment options, the most effective for long-term adherence. Are there continued managed use treatment options that are effective? Does it vary by substance and withdrawal period? Example, 90 days absence, then return to managed use.
I'll jump in with that one. I think that assumes we have some control over who presents to us and what they choose in terms of types of treatments from the menu of options. I think there's a selection bias there for sure, in that if we don't offer anything but abstinence-focused service, the people who are looking for harm reduction type interventions just don't get them.
I think there's also a bias depending on where you work. I think if you work in primary care, you're more likely to see individuals who may not actually have a substance use disorder. They may have some things that have happened as a result of substances, or they may have a milder disorder where certainly continuing to use substance or returning to substance use may be successful for them. When you work in a tertiary care center like I do, I end up seeing individuals who have had substance use disorders for a very, very long time. And so that being said, it may be their goal that they want to try to be able to control their use. And sometimes they may do that, kind of stop for a month and then try to manage it. But often when the disease is that progressed, it isn't always successful, but it's a place for further conversation.
I often think back to when I lived in men's residence at Dalhousie, which unfortunately has been in the news lately, but I would say about 60 to 75% of the people that lived there when I was there had what would be considered now an alcohol use disorder. But the vast majority of them over time were able to move on to having a relationship with alcohol that was in a more controlled, managed fashion, in a more healthy way. But then there's a certain percentage of those individuals that I treat now, 3 decades later, that were never able to control their alcohol use. So there's a wide continuum of these things. And so the one size fits all solution doesn't tend to work very well, nor are people terribly attracted to it. But there is a subsection of individuals, if they could control their use, they would control their use, and they cannot control their use. And I use the analogy with them of, the child with the nut allergy. Really profoundly unfair to have a nut allergy, but life isn't always fair. And you have an alcohol allergy, and that's really unfair because everybody wants to have a healthy relationship with alcohol, but there are certain people that want to have a healthy relationship with nuts, but they can't. And you have to deal with the cards that you've been dealt. So there's certainly a subsection that's really not an option, controlled use, but it does differ from substance to substance for sure. Whereas we know that abstinence-based treatments don't work very well for opioid use disorders, for example. And there's a different approach that has much greater effectiveness.
I think if you're encouraging someone and you're doing that kind of psychoeducation and talking about, drug holidays with possible return to occasional managed use, 3 months is a good kind of barometer to say, just from our neuroimaging evidence, that 3 months you do see substantive changes in the brain on PET scans, and that's when our kind of early remission is achieved on DSM. I think the other thing to really look at, to highlight in the treatment of addictions, which may have already been talked about today, is the involvement of your family and your peers and your friends, and how much, if you are looking at that kind of managed alcohol, if your spouse is a heavy drinker, that's going to be pretty tough. Or if all your friends do a ton of cannabis, you're not going to be sitting around the fire not using it as well. So, and the involvement of family and friends and caregivers is just so key, and we probably don't do that enough in our treatment plans.
There's another question about managed alcohol programs on an inpatient basis. Do they have a role in treating withdrawal? And what about treating treatment-resistant alcohol use disorder using managed alcohol programs? And I apologize, certainly in a talk of alcohol, again, it could probably be a whole day on alcohol. Absolutely, in Ottawa, there are managed alcohol programs. Usually they're set up such that they're places where the individual lives, and they can have a certain amount of wine every hour. So certainly that is an approach that is already used and has, some good outcomes for those who are treatment resistant and certainly do not want to stop using alcohol, as far as reducing, emergency room visits and harms. I believe, I'm not aware of any withdrawal management units where the goal is to withdraw people from alcohol, of having a managed alcohol program, but I am aware in some of the acute care hospitals, and that there are times when they will give individuals alcohol while they're an inpatient to manage their withdrawal while they're there having their acute issue dealt with. I don't know if anybody else from across, I guess actually you guys are all from the eastern provinces. I don't know if you're aware of any managed alcohol programs on inpatient units where you work.
I haven't been involved with one on an inpatient unit. We have a managed alcohol program that is relatively new in Nova Scotia, but I did have the experience of an addiction medicine provider, a family doctor really without addiction medicine credentials, formulating a managed alcohol program as a one-off for a patient who was basically dying at home in a small community in the Arctic. And this was in a long-term care facility, and it just kind of started prescribing alcohol to keep the person in the facility, and it made a huge, huge difference. And I've wondered since then about how you might formulate managed alcohol programs on a small scale rather than a multidisciplinary team with $1 million budget, et cetera, et cetera. I think it can work in non-traditional settings.
Similarly, I've seen it done with patients in our hospital that are being treated quasi-involuntarily for tuberculosis and things of that nature, where it really helps with engagement and reduces non-engagement.
Okay. Another question, given the increase in gabapentin street value, is there much concern about using it for treatment of withdrawal symptoms?
Yes. Again, we have control over what we arrange for dispensing. The problem with gabapentin is that when used for acute alcohol withdrawal, it's not just once-day dosing. And especially if you live in a rural place, a person can't go back and forth to a pharmacy 3 times a day for dosing. It's just not possible. So you can dispense daily, but you have to kind of work around some of these logistical issues sometimes. It's doable, but it's not ideal. I have patients who I'm convinced have just sold 2 gabapentin capsules every day out in front of the pharmacy for months or years.
I think it's very dependent on where you are and what people are abusing. But I think with anything that has potential, it's looking at those risk factors, who's at risk of abusing it themselves, and choosing if and when and how to dispense, as David mentioned.
It's the main drug of abuse in the First Nations community where I work. When opioids became unavailable, this is what was available, and now everyone uses it.
Okay.
Yeah, it's certainly, when you're looking at what's around, if kids are talking about it, if adolescents are talking about it and using it, that it's actually pretty accessible and prevalent because they have probably the least access. So I'm always, and you ask the value. How much is a gabapentin? How much is a Vyvanse? How much is, so it's being used, and gabapentin has gone up. So has Lyrica as well.
One easy marker is if it has a nickname, Xannies, Gabbies. If it has a nickname, it's out there.
Okay, another question. Can you comment on working with populations such as street impacted and some Indigenous trauma impacted groups, as well as immigrant groups? I think that could be for anybody.
This is a huge group in unfortunately people with addictions, because the childhood trauma, adverse childhood experiences, adverse buildup of trauma over your life, and a lot of these people have unfortunately had this either personally to them or intergenerational, and that's a huge risk factor for addiction. So I think it's challenging. I encourage people working with addictions. I encourage our residents to do a lot of research and work with on trauma, how to manage trauma, to read books like The Body Keeps the Score, to perhaps read some of Gabor Mate's great works, to look at that and recognize that as a huge risk factor, and also possibly a huge strength, the resilience they've built. And I also encourage people who do addictions work to really kind of think about the impact of that vicarious trauma on them, because it is quite exhausting and challenging. And so that need to kind of, to manage that yourself as well. It's not an easy thing to do.
Trauma can come in a lot of forms as well. I learned last year the reason why most of the patients I see with substance use disorders won't see a dentist. And it's because the community became aware 2 generations ago that if they were to see a dentist wouldn't treat them quite the same as a paying customer, a white man. They would often not use anesthetic, and it was traumatizing just to go to a dentist. And that kind of caught me off guard. I've led a different life. I don't know about these experiences.
I think that's one of the advantages of having an opportunity for our patients to educate us, and the importance of listening to them, because oftentimes their experiences really are inconceivable to us, and it's a great opportunity to build an alliance and a rapport where they're able to provide us with their expertise, and we bring our own expertise and hopefully meet in the middle.
I think another challenge is that when I speak of that vicarious trauma and working with these kind of populations, a lot of the impacts of physician burnout comes not from you not doing your own self-care routines, but the effects of the way the system is created to prevent care happening, and feeling like you're often beating your head against a wall when a patient is not ready, in quotes, or hasn't made contact in 3 months, so the file is closed and it has to restart again. So I think we create a lot of barriers for these kind of groups through the systems. So that's a challenging thing to look at too.
Often, people talk about compassion fatigue, but my experience has been it's much more bureaucracy fatigue.
Yeah, I would agree with that.
I think we're all smiling at that one. Okay, so we're just coming up on the end of the question and answer block, and there was a request to see Ronnie the cat again. Unfortunately, he is unavailable, so my apologies for that. So I thank everybody for joining us for block 1 and block 2. We will have a break that will run from 3 p.m. to 3:15 p.m. Eastern Standard Time. And our next block, we will have talks on opioids, stimulants, and concurrent disorders. And as you're listening to those talks, just want to remind you to put any of your questions in the chat. And also want to let you know that there is a spot where you're to fill out your evaluation. Now I've lost my notes, so where on the page it is. I think it's up on the far right side. So keep an eye for that. And sorry, the button's on the mid right side to take the survey around the evaluation, which will allow you to receive your certificate of completion. So we'll just break now for about 15 minutes, and we'll see you back at 3:15 Eastern Standard Time. And thank you for the speakers from block 1 and block 2.